study is on right leg pain. My patient is a 62-year-old female, reported having left knee pain that occurred September 2012. Patient received an MRI of her knee and her hip, and the images were clear. Then she had an MRI taken of her low back, and the physician found stenosis on L4, L5. Patient had a laminectomy and a fusion on L4, L5, October 15, 2012. Patient was DC'd to a rehab facility for 3 weeks and was able to ambulate 3 blocks and was making significant improvements. Patient was then DC'd to HEP. Patient reports since returned to home, her right lower extremity has been locking up frequently and giving her multiple problems. Patient was evaluated on January 24, 2013. Patient's chief complaint is stiffness and leg locking up multiple times an hour. Date of injury was September 2012, and here are my patient's self-reported scores. Patient's primary complaints. P1. Intermittent variable right lower extremity stiffness and locking multiple times an hour, with 3 out of 10 pain, causing difficulty in sleeping. P2. Intermittent variable burning pain in her right calf and foot, with 2 out of 10 pain. P3 is intermittent variable right lower extremity spasms with 3 out of 10 pain happening randomly. In the relationship between symptom areas, P1 and P2 are not related, and I feel like P1 and P3 could be related. Joints that could be involved is the lumbar spine, the hip, and the knee. Structures which may refer to the area is the central nervous system and the sympathetic nervous system. Contractile tissue, lower extremity musculature, and other structures would be nerve. My primary hypothesis is generalized muscle weakness, and my secondary hypothesis is an upper motor neuron lesion. Aggravating and easing factors. P1 aggravating factors is unexpected auditory, tactile, and visual stimuluses, and also being in one position for a long period of time. Easing factors for P1 is movement. So P2 aggravating factors is walking and sitting for longer than 10 minutes. Easing factors is rest. My patient has moderate difficulty sleeping. She wakes up frequently and constantly needs to change positions every 2 hours to get comfortable. Duration of current symptoms has been 2 months. And mechanism of injury, it's been a gradual onset. Progression since current episode is the same. Significant prior history is L4, L5 at laminectomy and fusion. Previous treatment, none. My patient has type 1 diabetes, high blood pressure, and she had arterial bypass in 2000. Red flag, she has numbness and tingling, but it could be associated with diabetic peripheral neuropathy. Yellow flags, she has high fear avoidance. She had an MRI done in her lumbar spine, hip, and knee. The medication she's taking is insulin, thyroid medication, Bistolic, Diovan, Lexapro, Lyrica, and Roboxin. The asterisk signs that I'm using from the history is over 15 episodes of lower extremity locking out per hour, which takes about 45 seconds to return to baseline, as well as 2 hours of sleep until woken up by locking spasms on the right lower extremity. My primary hypothesis is generalized muscle weakness, and my secondary hypothesis is an upper motor neuron lesion. So things that I ruled out through my history was for musculoskeletal, right knee pathology, and non-musculoskeletal cancer. The severity of my patient's condition is severe. Patient has difficulty with increased time for her ADLs and needs moderate assistance from her husband. Irritability is severe. Patient has minimal activity that brings on symptoms and takes about 45 seconds to return to baseline. What is my primary nature statement? Is neuromuscular. And what is the stage of the disorder? It's proliferative and it's remained the same. And the stability of the disorder, it's unstable, non-reproducible symptoms that are present every day. So I'm going to include Babinski's and Clonus, NeuroScreen, and Mayo Muscle Test to rule in or rule out my hypothesis. I deferred the Mayo Muscle Test the first day, secondary to my patient's constant locking out of her right lower extremity. For the physical exam, my patient had precautions of no bending, lifting, twisting of the lumbar spine since surgery. Postural observations, no abnormalities. Functional movement analysis, patient had a rolling walker with right circumduction gait. A quick screening test, I was unable to clear additional joint structures secondary to the constant locking out of the right lower extremity. A neurological exam, the dermatomes were intact and equal bilaterally, myotomes unable to perform, and reflexes were absent bilaterally, and upper motor neuron lesion tests were absent bilaterally. When I palpated my patient's lower extremity, her entire lower extremity was tender to palpate with pain and wincing. She also had pitting edema. All the other objective measures were deferred due to multiple incidents of her right lower extremity locking out. My primary hypothesis following the physical exam was a motor neuron lesion with high fear avoidance behavior. In the history, I found fear of movement and sudden changes in recovery of status post L405 laminectomy infusion. In the physical exam, she had diminished reflexes. Her dermatomes were equal and intact bilaterally, but further examinations had to be deferred secondary to patient symptoms and muscle spasms. Plan of care. Patient's prognosis is fair and would take around 2 to 3 months of therapy. I'm going to see this patient 3 times a week, and my patient-specific goals for therapy is to ambulate with normal gait pattern and without assistive device in 6 weeks, and decrease her frequency of locking out or spasms to less than 5 times an hour in 3 weeks. I'll know that my patient's ready for discharge when she's able to ambulate without a circumduction gait or reduced frequency of locking episodes to perform her ADLs. If my patient's not making progress, I'm going to stop treatment around 3 weeks or after all treatment options have been explored. My overall management strategies is to initially perform low load with long duration exercises to decrease edema and locking out symptoms and promoting activity tolerance. Also include dry needling and eye stim to decrease her hypertonicity.